Acne is the most common skin condition in the US, and oral antibiotics are the most commonly prescribed systemic acne treatment. The CDC annually publishes data on antibiotic prescription rates, and in 2020, dermatologists prescribed the most antibiotic prescriptions per provider, far outnumbering any other specialty. And this is actually a trend that's been consistent since 2011 when the data was first published and released. There are multiple treatment guidelines for acne, and the AARS specifies that we discontinue oral antibiotics within 1 to 2 months once new inflammatory acne lesions have stopped emerging. The AAD states that we should ensure that patients with moderate to severe acne receive no more than 3 to 4 months of antibiotics, and the Global Alliance to Improve Outcomes in Acne recommends we limit the duration of therapy to 3 to 4 months. However, adherence to these guidelines in actual clinical practice remains inconsistent. In this study, we examined the determinants of limiting antibiotic prescriptions to no more than 3 to 4 months in clinical practice. We started by sampling key stakeholders from the community. This included providers from the AARS, the Georgia and Atlanta Society of Dermatology and Dermatologic Surgery, providers from Emory's Department of Dermatology, and infectious disease specialists from Emory's Antibiotic Resistance Center. This is part of a larger mixed methods study where we gathered qualitative data from interviews with participants. We also gathered quantitative data from surveys we administered. And today I'll be focusing on the results from the quantitative side, where we administered the Influences on Patient Safety Behaviors Questionnaire, or the IPSBQ. This is a sample of the IPSBQ that we administered, and this is a validated, theoretically driven survey, and it was designed specifically to assess the determinants of certain behaviors, and so we adapted it to identify the influences to ensuring patients with acne receive no more than a total of 3 to 4 months of oral antibiotics. There are 23 items in total, and each item or statement corresponds to one of the domains in the theoretical domains framework, which is an implementation science framework that helps organize theories of behaviors into constructs or domains. Participants were able to rank from 1 to 5 or strongly agree or strongly disagree to each statement, and a higher score corresponds to a higher barrier, and a lower score would correspond to a lower barrier to antibiotic stewardship. We sampled 30 total stakeholders, most of which were dermatologists. We also included dermatology APPs, residents, and infectious disease specialists. Most of our participants identified as non-Hispanic white, and the distribution of male to female participants was roughly 50-50. This is the results from the IPSBQ. This graph is showing the mean scores from the IPSBQ domains that we assessed. The highest possible mean score for each domain was 5, and again, a higher score corresponds to a higher barrier to antibiotic stewardship. And we found the strongest barriers to adhering to the guidelines were social influences, beliefs about capabilities, memory, attention, decision-making, and environmental context and resources. The lowest barrier was knowledge, and the domain that had the most varied responses were skills. And so breaking down each of the barriers, starting with social influences, this is assessing whether dermatologists believe that other dermatologists or their superiors seem to care about adhering to these guidelines. We found from the IPSBQ, dermatologists don't seem to think that other dermatologists care about adhering to the guidelines or that their superiors don't necessarily want them to adhere to the guidelines. Beliefs about capabilities was assessing whether dermatologists trust their abilities to ensure patients receive less than 3 months of antibiotics. And we found that dermatologists typically do not find it easy to adhere to these guidelines and that they have encountered problems when trying to do so in the past. Memory, attention, and decision-making was also a high barrier that we identified, and this was assessing whether dermatologists are able to recall the guidelines in clinical practice, or when they're faced with the decision to limit antibiotics or to continue them, what decision do they make? We found that dermatologists habitually do not follow the guidelines, or when they don't decide to follow the guidelines, that they have justifiable reasons for not doing so. Environmental context and resources was assessing whether the clinical setting itself or the resources or lack thereof was making it difficult to adhere to the guidelines. We found dermatologists feel that there's not a good enough system in place to adhere to these guidelines, and that they are lacking in the necessary resources, or verbal or written communication between staff may be lacking to help ensure that the guidelines are adhered to. The lowest barrier we identified was knowledge, and this is assessing whether dermatologists are aware about what the guidelines say or whether they agree with them. And because this was the lowest barrier, we found that dermatologists generally are aware of the guidelines and that they generally do agree with what's stated in them. The domain with the most varied responses was skills, and this was assessing whether dermatologists felt that there was enough training that was adequate or regularly offered to adhere to these guidelines. And we saw varied responses such that each participant varied in whether they felt the training was adequate to help them adhere to the guidelines in place. Based off of our survey, we found that the strongest barriers to adhering to guidelines for antibiotics in acne treatment were social influences, memory, attention, and decision-making, environmental context and resources, and beliefs about capabilities. Now that we've found these relevant barriers, we believe targeting them may reduce the overuse of oral antibiotics in acne. The domain that had the highest variance was skills, and again, we were looking at whether training was adequate enough to help dermatologists adhere to the guidelines. And since there were such varied responses, additional training may not necessarily be helpful or the most efficient way to reduce overuse of antibiotics. And with that, I would like to extend special thank yous to each member of our team, especially our PI, Dr. Howa Young. I'd also like to thank the AARS for this opportunity, funding, and for help in expert recruitment. And finally, I'd like to thank each participant in the study for their support in this research project. Thank you.